Good afternoon, everybody. It is Friday, and it is Friday the 13th. You're here at Lunch and Learn. We have a guest speaker today, Dr. Kelly Miller. He's going to be talking about primitive reflex and delta, something that many of us haven't heard of. We were just talking before we got started here with Dr. Kelly Miller about how he sort of came to be aware of this whole process. So instead of doing a lengthy intro, you've seen his credentials. He is certified and board certified in a variety of chiropractic and other health-related areas. So he's going to talk to us today about this primitive reflex. We'll take Q&A towards the end. I'll give Dr. Miller maybe a 10-minute warning towards the end of the hour, and then we'll go from there. So without any further delay, Dr. Miller, thank you. We know you're a busy guy. He's actually flying off after he gets done with us to go give a lecture in Texas. So we appreciate your time with us today. It's all yours.
Well, thanks. I really think I'm going to enjoy this. This is just give you a little background. You know, I've been in practice for 43 years, as I shared with you, but the other attendees didn't hear that. I started out in chiropractic and then doing a chiropractic and nutrition seminar or practice, and then I got certified in acupuncture. Later became certified as a naturopathic physician, and then on functional medicine, and then did a fellowship in aging regenerative medicine. So I've always been a lifelong learner. And I started, I guess, doing brain mapping neurofeedback in 2018. And after I had a brain map done on myself, and the guy goes, "Wow, have you had concussions before?" I'm like, "Well, yeah. As a matter of fact, I have." So I thought that was interesting that he could tell that I had concussions, and I was actually and he goes, "Are you having hearing problems?" I go, "Well, actually, I am." Yeah. So I obviously was having something going on in my temporal lobes there. But anyway, one of the things I'm excited to talk about is the primitive reflexes, and I wish I knew 43 years ago, I knew what primitive reflexes are. And I think they're so important and they're so relative to today. And I'll share a little bit with you why I think that. In today's world, we have 10% of children are classified as ADHD. And then we have about 2.5% now in the spectrum. And we have about 15% dyslexia. So we have 20 to 25% of the children in today's world are having neurodevelopmental issues. And this is accelerated, you know, from 40 years ago, and a lot just in 10 years ago and 20 years ago. But in the adult population, we have about 20% of people that are medicated for major anxiety disorder, and about 7 to 9% for major depression disorder. And my God, there's millions of people have insomnia. So what we see almost universally, at an age when we have these patients, is we find 95% of them have these primitive reflexes, whether they're 8 years old or they're 80 years old. And I used to think that in the old people that maybe they just came back because you can get a concussion, or you can get an infection. We find a lot of primitive reflexes come back when people get mold infections. But anyway, I was on a mission after my seminar about 2 months ago that I was going to check everybody's primitive reflexes, and we were just really going to work on integrating them. And we integrate them by stimulating the brainstem with the Avant laser on a specific setting of 10 hertz red light, while we initiate the primitive reflex. This helps get it integrated and gets rid of it. So that's what started this. So, you know, my understanding from brain mapping is that when we see high delta, that's usually, you know, environmental issue. You know, the front part is heavy metals generally, or, you know, concussions and things like that. And that's what I thought too. And then I had, after we did these remediation of these primitive reflexes, I started wondering if we're seeing something else sometimes in people. And there's no doubt that that the high delta is, I see a lot of environmental issues with that. But I had 4 interesting cases all resolved, and in my practice I do 16 treatments and reassess. So I don't know how I came to that, but anyways, I think we started out because we were seeing 2 times a week, and we saw them 8 weeks. It seemed like a good time. But if we see someone 3 times a week or 4 times a week, we do the same protocol. This is a 12-year-old boy who is father threatens he's going to off him so much because the kid is just so hyper and so talks so much, and he's crazy about computers. But anyway, we do neurofeedback on all patients, but we also do Dr. Melillo method of hemispheric integration, picking where we're strengthening one hemisphere. And most kids who have ADHD, OCD are right hemispheric weakness. And so we're doing primitive reflex integration with the laser, work on core strength. We do vibration, light, sound, different things for that. And this is his brain mapping before and after. And this was really a remarkable change for me. I mean, I don't know, you guys, I'm sure people watching have done a lot more, been in neurofeedback a lot longer, but for me, this was like, oh my gosh, this is like, wow, look at the change in his delta, generally the brain. So I thought that was pretty good. And, you know, I started thinking, and I don't know a lot about this, but generally, my understanding that delta is very prominent in the first 2 years of life. You know, the baby's sleeping all the time, their brain's not really active. Then theta gets involved from 2 to 6, and then 6 to, I think, 10 more alpha, then after that beta. So what my question was this delta a lack of maturation in the brainstem with the primitive reflexes and keeping the brain in a more younger primitive state? So that's my question, I guess, my query. So this, and the child's behavior improved quite a bit from this, and this is where we saw the most changes. Even though in neurofeedback we're always doing a symmetrical. It's interesting because I think we were working on either T3, T4, or F1, F2. So the changes were not where we were. We weren't in the occipital or the parietal lobe. So if anybody has any questions or anything, they can. We'll wait till the end, or. So here's another 13-year-old. We just turned 14, and the previous one we saw 2 times a week for 8 weeks. This child we saw 3 times a week for basically 5.5 weeks. And this child was, you know, an inch away from being Baker Act and just being institutionalized. And he hit his parents and older brother almost every day, threatened to kill him with a knife. The mother was told to give up on homeschooling, that they just need to try to get him maybe some vocation that someday he could work part-time. And he was on lots of meds, and they were, you know, basically trying to sedate him. And he was a big kid. He's like 5'10", skinny kid. So this is, so let me back up a second. It seems like I lost the, I didn't, somehow I missed the neuroplastic changes. This child had like 48% neuroplastic changes, which is another thing that I don't usually see. You know, usually I used to do, if I got 30% neuroplastic, 30% normalizations here. So this kid had a huge change, 46% neuroplastic, 53% normalization. So that's pretty good. I don't know. You guys can tell me. I thought it was pretty good. But then this is, again, we see this huge shift in delta now, and literally this kid had every primitive reflex, and his behavior was like a 3-year-old. You know, he's like a 2 or 3-year-old that could talk a little more. He only had he had 2 emotions, happy and angry. So basically, as long as he got whatever he wanted, he was happy, and if he didn't, he was angry. And then he would throw tantrums and wouldn't cry, but he would rant and rave and flop around the floor. What's pretty cool about this kid is this kid started saying he's sorry and hugged his mom, started hugging the staff, told his mom he loved him. So it's pretty cool. This is where it changes in here. Now, this is interesting to me too, because in this case, this kid had incredible right hemispheric weakness. And in fact, in the basal ganglion and the insula on the right is where our bad behavior lives. It's our inhibitory part of our brain. So our left brain is like, you can do it, go for it. And our right brain is like, maybe we should think about it, caution, you know, safety. And we were really working the right side in this area, and that's really where, you know, F8 and T4 are. But it's interesting, the other side also normalized, because so if you think about the left side is hyper and this right is under functioning. So the do it now was over functioning, and the let's wait and see, or let's do caution, was under functioning. That makes sense. So this is a 15-year-old, again, this is a Chinese orphan who's, you know, they went over the orphanage and got her, and so she was one of 800 children, you know, so had very poor, you know, laying never nurtured, never picked up hardly, and you know, so research shows that their brains atrophy a lot. But anyway, they had worked a lot of hard, you know, to do a lot of different things with her. But she was definitely emotionally less mature than her 15 years old. She was starting to have some seizures, learning challenge, and this is her change. So again, she had primitive reflexes, and we worked on the primitive reflexes. And really, this one we worked with her 2 months, and her parents bought a laser and bought all this equipment and did basically simulated our brain clinic at home for her. So the question, we had lots of environmental thing, you know, she had environmental things. We retested and they were actually worse, but when we went through the primitive reflexes and all these things, then it cleared. So this is where her changes were. See that F7-8 again, which is that insula area kind of. And the dorsal column. Now this is the contrary. This is a 78-year-old dementia patient, and they came from Indiana, and they had a house near here, and we saw him for 2 sessions. We do, most of our sessions are 90 minutes. We did 3 hours a day, twice a week, so that he had 2 30-minute neurofeedback sessions. So in our clinic, we usually do the neurofeedback's 30 minutes. We're doing about 45, 60 minutes of, we call it brain training. And this is a guy who, you know what the Stroop test is, but anyway, we have it's a filtering test, but we also have something called go, no go. You might know that, but basically on a big screen, you either have a number, letter, or a picture of an animal, and they're either the same or different. And so if they're different, you touch the one that's inside the box, and if they're the same, outside the box. So with prompting, he would do this in 5 to 6 seconds. We go, the same or different. And we got him down to 1.3 seconds. So his decision making was better. This is a change. This is a 75-year-old man. Again, 16 treatments. And this we say we actually his brain speed improved. Overall brain speed. Which was shown from the go, no go, he was doing that much faster, his decision making. And this is this guy's. So he had big improvement in delta and theta, which are just as slower brainwave activity. Improved. So that's again, and his primitive, he had primitive reflexes. He had a rooting reflex and a palmamental reflex, which is when you stroke the hand and you get contractures in the chin. And these are all that, and the snout reflex, if you tap on above the top of the lips will purse. So if you, on my website, www.savingyourbrain.com, we have a demonstration of all the primitive reflexes for those that aren't that familiar with it. But those reflexes are all inhibited by the frontal cortex. So when you have a dementia patient, you have someone who is losing frontal cortex function, these primitive reflexes will manifest. And conversely, as their frontal cortex function improves, these primitive reflexes will dissipate. So this was we were focusing most of the attention on his left side. So the kids, the ADHD kids and all the autism, well, thought I turned that off, sorry, are more right brain weakness, but usually when the dementia, Alzheimer's and Parkinson's are left brain weakness.
Fascinating stuff.
Okay, any questions, comments? I guess my curiosity from among everybody who does neurofeedbacks, are those better than average changes you would expect in 16 sessions, and that much change in in the delta? Is that something typically?
It is from my perspective as somebody who sees thousands of maps pre-post. It's pretty dramatic and unusual.
Okay, well, that's why I thought I might be onto something there.
Yeah, what do you think, Rob? What's your take?
Yeah, I would agree. That's an incredible change in a very short amount of time, especially if you're dealing with somebody who's had a head injury that resulted in even a mild TBI. We usually imagine, minimally, 40 sessions, 30 to 40 sessions if it's a mild TBI, and more often than not, it takes longer than that. So, yeah, and the changes may not be as dramatic as we've seen from the slides you showed us.
Yeah, those
Well,
are very
they're getting other things besides neurofeedback. Yeah, we're doing lots of other stuff with them too, but that's,
yeah.
That would be my comment as somebody whose population is TBI recovery. I want to compliment you, Dr. Miller, on the multimodality approach. That's essential. And so your results don't surprise me, and just kudos to you.
Yeah, thanks, Becky. This should give us all pause and get us thinking about other methods of intervention, like using cold lasers. Is that a cold laser you're using, Dr. Miller?
yeah, basically what we do is we do a 3-pronged approach. So we use we use a bottom-up approach. So we're looking at the brain neurodevelopmentally. So we're looking at brainstem, cerebellum, vestibular, oculomotor. You know, what is it that's out of whack, and we work on it that way. So we work on people's balance and on their cerebellum, and then we do a lateralization treatment where we stimulate one side of the body to the opposite hemisphere. So we'll put like a Resimax. There's a varying frequency between 10 to 40 hertz, which is all good frequencies for the brain, and we'll put it on. So the right brain weakness we'll put on their left arm, left leg, and then we will actually we use essential oil into the right nostril because our smell is ipsilateral to the same side of brain where everything else is the opposite. And then we do things like interactive metronome, and we put the sound only on the left side also for doing a right brain. And we have them work their left arm. So all the stimulus on the left to push it more to the right. And we put sound and vibration and smell to create a bigger connection between networks. And then we use a laser on their cerebellar side. Well, I mean, 99% of the time they're weak hemispheres, their opposite cerebellum is weak. So we're co-lasering that while we're stimulating parietal, temporal, occipital on the opposite side, sensory motor line on the opposite side, and then the frontal cortex. And then we'll actually look at some of the people, and when we'll specifically treat Brodmann areas, you know, like for an aphasia patient or, you know, whatever, or like I said before, with the right basal ganglion and insula area for the behavior. So when someone has bad behavior, we found that area in the brain with the laser. And
What oil are you using?
I'm sorry, what?
What essential oil are you using?
For the right side, we use peppermint or frankincense. And on the left side, we use orange or lavender. Stimulates the brain. And we use the Avant laser. And so I actually have, it comes with about 300 different settings and 250 from the manufacturer, and I have 50 proprietary saving your brain frequencies that are specific to different areas, like Broca's areas, or work different parts of the brain in different frequencies. So basically with lasers, if you're not familiar with lasers, what they do, they increase circulation, and they actually, the mitochondria in animal tissues are sensitive to light. So if you're able to get the light in there, it activates the mitochondria. So you're actually increasing cellular energy to the weak areas. So from our evaluation, we find where the weak areas are, and we stimulate those. The interactive metronome is a really good tool because it coordinates, synchronizes cerebellar, parietal, and frontal cortex function. We'll also have them we do something on balance plates. We also do eye tracking exercises, which will activate different parts of the brain. And then we'll, again, co-activate with those sensory inputs and laser. Then, of course, we finish everybody off with neurofeedback. And we
Dr.
also,
Kelly, oh, I'm sorry,
yes.
Go ahead. Go ahead.
No, I said the other thing we've done, we use something called BrainTap, which is a audiovisual trainer. And so based off the brain mapping, I'll have the patient do specific frequencies to whatever their weakness are. And we created basically frequencies that we can do left and right brain for avoidance and over arousal, you know, to help balance the beta and alpha in the left and right hemispheres.
I was going to ask that with the laser, what kind of light is the laser?
What kind of light? It has an infrared and a red light setting. I don't
Okay.
recall exactly what the angstroms are. It's actually on my website, but I don't remember them right there.
I was curious because some of us use devices like something called, there's one company that makes one called the V-Light, and then there's other companies that make helmets, and all those involve infrared light, but at different frequencies. So I was just curious if that's
Yeah,
if
so
that's similar. Yeah.
I used to use a device that symmetrically increased the circulation of red in the brain. But what we found is, so now then we use a laser because it's more specific, and we only use on the weaker side. Because if you do infrared globally, the stronger side will get stronger, and the weak will get, even over time, you will get more separation. If you got too much, does that make sense? If one's, it's like I used to be equally strong, and I used to do bench press with a barbell, but then I broke my arm in a cast for 8 weeks. I can't go back and use that barbell. All will happen is my left arm will get stronger. That makes
Yeah,
sense?
that makes sense. Yeah, doing one side. Yep.
Yeah.
Understood.
So we try to be more discriminatory and more on doing the weaker side.
There were very high levels of change, and they were very specific to the delta frequencies, and a lot of the other frequencies did not change that much in several cases, except maybe one, which suggests it's a really highly focused intervention that really affects specifically delta, and that's what makes it so intriguing. I know that you were looking at the areas that change were often different from the areas that you were stimulating, but that's a principle we've seen in biofeedback and neurofeedback, since the 70s or 80s even, that when you intervene, the brain and the central nervous system is so complex, you don't know how they're going to adapt. So the way they adapt is always unique, regardless of the intervention. And I think you see that when you train people in the old days at CZ with SMR. Everybody's brain changes uniquely, and not necessarily at CZ. It could be the whole brain or parts of the brain. So I think it's almost impossible to predict what areas would change consistently, although there may be, as you say, it may be insular areas tend to be a consistent pattern. I mean, that wouldn't be surprising based on what you're saying, since that's the main, one of the main areas of intersection between the ascending reticular system and the vagal system and the thalamic system. They all innervate the insula intensely and affect arousal left versus right. So that all makes perfect sense to me, anatomically and physiologically. And I was surprised at the symptom variety that was associated with the elevated delta. Now, of course, we're not looking at the whole rest of the other neurometrics. So if we looked at all the other neurometric dimensions, we may find unique patterns in the other dimensions that are associated with that delta. And obviously, you would probably need statistical analysis to sort that out, but it opens.
Yeah, generally I'd say they all have low beta.
Yeah, did you see that consistently too?
Yeah, very low beta, and almost like we had this conversation before, it's like almost everybody has low occipital theta. I mean, that's like almost probably 9 out of 10 patients at least, or if not even more.
That's anxiety usually. That's related to anxiety, and the low beta is usually related to the body's inability to produce enough ATP or energy.
Yeah, well, if you think about the primitive reflexes, what they do, which I didn't say initially, but one of the things that they do is they help mature the vagus nerve and which controls the parasympathetic nervous system. So all these people are in fight flight and they're all anxious, and they all have sleeping problems.
Oh, that's very interesting. And a really important point too.
And so when they, so we put a pulse ox on them, and their heart rates are all elevated. And then when we get the laser and we integrate it, we'll actually see their heart rate drop. And not only that, you see their pupil size shrink. So all these people tend to have larger pupil size because of the lack of the parasympathetic nervous system. And when we stimulate the vagal, the brainstem, the pons medulla area, that improves their vagal tone and it's parasympathetics, and literally these kids look like they melt, this because they've never been able to down regulate.
This would make a great article with these several cases in a row. It's really intriguing. And it forces us to rethink about what the source of the elevated delta is in head trauma and other things. I mean, maybe that the head trauma also affects these primitive reflexes. From your perspective, could that be possible?
No, that's true. I mean, it's in the literature.
Is it?
Yeah, the concussions cause primitive reflexes, or high findings of people suffering from post-concussive syndrome is they have the primitive reflexes. So it even begs the question, is the reason they're not recovering as well is because they have the primitive reflexes and they're, I don't know.
Absolutely, and that would also, I assume, create sleep disturbances with those primitive reflexes based on.
Oh yeah, these kids don't sleep. They come in, the parents come in and they got videos of their kids up at all hours of the night trying to do different stuff. They come in their bedroom at 3 in the morning, wake them up.
Right, so that ties together the literature on head trauma and sleep, and that one of the best measures of recovery from head trauma is sleep quality. So now we've got this other area that we can look at as a source of problems, that the primitive reflexes may be tied to both of those, and a real missing piece.
Yeah, but before I knew about primitive reflexes, I did heart rate. I still do heart rate variability, but what I was finding, all these people that didn't respond well usually had, very low parasympathetic function. They were always in fight flight.
And these were the people who are having trouble with heart rate variability in your office.
Right.
Mm-hmm. Yeah, there are some people I've had who just, no matter what they did, they could just not get any control over heart rate variability. And this is potentially an interesting place to look into for these people who can't gain control of it. And also why they are not as respondent to neurofeedback is that if we address these primitive reflexes, they may suddenly improve their adaptability.
Yeah, so it seems like when we get the primitive reflex, we get the brainstem functioning better, that all these systems, so the analogy I look at is like, if it's the brainstem is like the foundation of your house.
Mm-hmm.
And if you didn't pack the dirt down in one corner before you poured the concrete, it starts raining, it's gonna crack, and the floor is gonna sag, and the walls are gonna crack. All these systems are built on that. And
Yes.
so you have problems with the vestibular system, oculomotor system, either balance, cerebellum. And then when that comes in, all these systems seem to like boop, 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 start coming on board and functioning better. And the other thing about primitive reflexes is they're associated with specific weird neural behaviors. For example,
Yeah.
like spinal galant, the kid's fidgety. He's just like, he's hyper. He's like hyper vigilant. He's always looking around. He's shaking his leg. He's doing, also often bedwetters past the age of 5. Lots of different things like that. So you'll have these different neural behaviors which will go away.
I
Well,
went ahead and
go ahead,
posted
Ron.
a little article on what primitive reflexes are on the listserv for the folks attending if they're wanting a bit of a refresher, just so you know I've done that.
That's great. And I've worked with a lot of chiropractic neurologists. Some working with Carrick and the others with Melillo. And but regardless of who I'm working with over the last 15 years, and I even was affiliated with a chiropractor who was doing a lot of work with Carrick and neurofeedback, and I was working with him on the neurofeedback side, which is how I even know about some of this stuff. And I had him working with my own child, and I was amazed at things that he was discovering, like he couldn't smell the difference between different smells. It's like no other doctor told us that. I saw it in real time as he was testing that and other primitive reflexes, and I was like amazed. But I don't think we were implementing that particular intervention specifically enough to kind of really uncover this. I think it's great that you have, but I noticed that most of the chiropractic neurologists I worked with were monitoring primitive reflexes and adjusting them, and I never thought of that as being one of the major impacts on the brain in the delta frequency. Although they had said it really helps with the neurofeedback, but you've got such great pre-post case documentation here that it's really impressive. So all these chiropractic neurologists weren't just getting, 40 and 50% changes in pre-post maps because of nutrition, which I attributed it to was the nutritional component, but also, it validates this intervention that you're using here and the perspective that you take, which doesn't need validation in your own field, but from our perspective, it's like, well, what are these primitive reflexes and why should we pay attention to them and why isn't anybody else talking about them? But this really helps lay out the story right here, what you're presenting.
Yeah, I mean, it's so important to me. I think, like from a chiropractic perspective, this would be something the freshman year you should learn right away, because
Yeah,
we're talking about a huge impact on 20-25% of the population of the world, children and adults. So if you, like when you have somebody has a startle reflex, they're just miserable. They're just in fight flight. They can't function.
yes.
They're medicated. They can't sleep.
It's a common feature of PTSD.
Yeah, you change. Well, that's it. Yeah, Well, I'm actually treating a Navy SEAL guy who, anyway, he multiple injuries, concussions, and had a bad helicopter crash, chronic pain, and multiple spinal surgeries. Stuff. But yeah, he's definitely PTSD. But most of the people that PTSD have grew up with avoidant behavior, from their parents. They had no nurturing, and they didn't have coping mechanisms.
Yeah, if we're talking about developmental trauma or toxic
right.
stress, yeah.
And that's what, same way this guy, his dad beat him horribly and beat his wife, and he beat his mom, and in front of him, and so he became Superman, Navy SEAL. So
Yeah,
nobody can hurt him anymore. But when his body doesn't work anymore, now he's freaked out.
vulnerable. He's vulnerable again.
Yeah, he's vulnerable. Exactly.
It'll
Oh yeah.
bring all his issues back up of now what do I do since I can't be Superman to save myself anymore.
Right.
How
Can't
can I protect
yeah,
myself?
he can't save his family. He can't save his brother.
Even worse, yeah. Yeah, that's really intriguing.
Dr. Miller, have you worked with children with severe attachment disorders, particularly adopted kids?
I have not. I've had some worked with adopted kids, but that was not a major feature. This kid that had the ODD, and he was adopted kid. He was adopted. The Chinese person was adopted, but so they may have had that.
Yeah.
They may have had that classification if somebody had seen them. I don't know, but I'm just trying to find their weaknesses and shore them up.
Isn't primitive reflexes related to the level of interaction with the caretaker? Am I wrong on that? Does it help resolve that if they have enough stimulation early in life?
You almost see universally C-section children have primitive reflexes. Like both my youngest daughter had C-section, and both her children had spinal galant and asymmetrical neck reflex. And I worked on them, and so it's I'm not sure, I know that's a very universal thing, but it's I don't know what other factors play a role in why they aren't integrated. But there's several things you can tell, because the kid isn't crawling like an army man. They're not creeping on their hands and knees, and they don't go through these all those kids, when you go back in their history with their parents, they didn't go through some of those milestones.
Right.
Can I just ask you to clarify real quick that three-prong approach? Number one was the neurodevelopmental brainstem. Two was lateralization. What was number three?
I'm sorry. I think you said, what was the three approaches?
Yeah, it was the three-prong approach.
Three-pronged approach, yes, you're right. And I didn't say the final three. The other is top-down, which neurofeedback, I think, is a top-down approach. And the brain tap is a top-down approach. So we do all three at the same time. We do the bottom-up, the lateralization, and so we all do it in one treatment.
So you do them all in one session. It's not like a systematic thing.
In a 90-minute session, right? We'll do all that in one 90-minute session.
So it's kind of, in other words, it's a stabilization, getting them out of fight or flight, then correcting for asymmetries, and then going to the top down, correct?
Yes.
Thank you.
Yes.
Well, nice summary, Becky. Good. That was helpful.
Yeah, I think and thank you for reminding me I didn't finish that thought. That's I think when it's done like that, we get more stickiness. When I just know when I miss primitive reflexes, it seems like people will get better, but it didn't stay.
Right, and you don't get anywhere. They don't integrate the learning. If they're still in fight or flight, they're not going to be sleeping. They don't consolidate the learning. They don't really get anywhere. And Dr. Suter, you mentioned that both of you mentioned about HRV. HRV training, I actually start with that. I collect data for the brain map, then I go directly to HRV training. If they don't make progress, then I know we're still in fight or flight. I do a lot of peripheral feedback just to get them stabilized and out of fight or flight. And sometimes the biofeedback, no matter what you're doing, be it neuro or peripheral biofeedback, you still don't get anywhere if they're really in fight or flight. And how do you know if you don't assess for that? And that's where I use that multi-modality approach like you do, Dr. Miller. I mean, you're doing a fabulous job. I'm super impressed. But that's where you use the stimulation technologies to kind of override it and get that brain out of fight or flight. Very helpful.
Yeah, excellent point. Excellent point. Explains a lot, doesn't it?
Yeah, I mean, looking back on all these patients, failures, I guarantee they all had primitive reflexes, and we didn't get rid of them. If we got rid of them, they would progress more. I'm just thinking like functional. Everybody has adrenal fatigue. Everybody has hormone problems. Well, if you're in fight flight all the time, if you're that's creating that scenario.
Yeah, that's another refinement. I think we should get you and Becky together to compare notes, to
That would be
translate it.
great.
Where are you at,
Translate
I
it.
would
Becky?
love that. I'm actually on a little sabbatical right now for about a month or so, and
Where you live?
I'm in Southern California.
Southern California,
Oh, okay. Well, I'm going to be in wine country in
2 weeks.
2 weeks. So.
I'll be good.
Oh, that's close by. I'm kind of just south of Central Coast between, I'm in Ventura County. I live on the beach in Oxnard. So,
We're going to be in
but that's
Sonoma
not far.
County.
Where?
Sonoma
Awesome.
County.
Right on. I'll back channel me or I'll back channel you, and I think we have a lot to talk about.
Yeah.
Will you share your notes with us neophytes?
Yes.
100%. I'd be happy to. And like I said, I have some time now. So yeah, I would love to help out anybody who's interested.
Hi, Dr. Miller. This is Mary Ellen. Before we end, I just have a question because I use interactive metronome, HRV, infrared, essential oils. So
Cool.
yeah, for years, many years. So I want to thank you for educating others. And also, when did you use the metronome? Just with your Parkinson's?
No, I use it on every patient. So we do.
First, before neuro?
In the same session, I'll do it before the neurofeedback. But
Before the neuro, okay.
so I do. Yeah, we look at primitive reflexes. We work on core strength. A lot of people will have very asymmetrical core strength. Like you can just do a side plank on one side, do a side plank on the other side. There'll be a big difference in their strength.
Okay.
We work on, but the interactive metronome, we do the 14 checks on everybody, so we see how bad their timing is, which ones are like both hands, right hand, left hand, both feet, right foot, left foot,
Oh.
then back, and then right heel. You know what I'm talking about? There's a
Yes.
long
So how
form.
many minutes do you do of IM?
Varies, probably 10 to 15.
Okay.
And we do it on one side predominantly. So like if I'm trying to strengthen the right hemisphere, we'll do all left. We'll do left hand, left toe, left heel.
I see. Yes. Makes sense. Okay.
And then we'll do complex. We'll do right hand, left foot, left hand, right foot. Or we'll do whatever their weakness is in.
Okay.
We'll have them step backwards, or whatever.
Yeah. Okay. Thanks. You're not coming to Arizona, are you?
I think he needs to do a workshop in this.
Okay, let's set it up. Whatever you want to do.
A workshop in Napa Valley would be great.
Yeah.
It would be.
Not this year.
If you're interested, I'll also have you think about doing a webinar for ISNR, just like you did today.
Okay, well, just tell me whatever that will entail.
I'll email you separately about that, probably sometime next week.
Okay.
Give you a break since you're traveling, and you're going to have a lot of requests from this group. So,
Yeah, this is very fascinating. And the way Becky started to parse it out was very interesting, coming from more of a biofeedback, neurofeedback approach, but with other interventions she uses. It suggests that there's several ways possibly to do this, huh?
Yeah, I think it's when something isn't working, it's because one of those components isn't being met. Does that make sense? I think neurofeedback's top down. So if you have too much bottom up deficiencies, you're not going to maybe get the best results.
That's an interesting idea just in itself. I mean, this kind of calls up a lot of interesting questions and points us in some interesting directions in terms of dealing with stubborn delta. It's really a fascinating door into new possibilities, which is why I asked you to do this presentation. I was like, this is pretty amazing. I do a lot of mentoring and consulting and over the years, but I've rarely seen this type of consistency, and it's fascinating, and the intensity of the change is amazing in such short time.
Yeah, so if we continue to work with these people, then I would hypothesize that, you know, if it's a lack of brain maturation, that as they go through, then you're going to see improvement, and then the alpha and then the beta. So in other words, if someone's 14 years old, but they're acting like an 8-year-old, you're not going to expect a lot of great beta activity in that kid, right? Am I thinking that correctly? But if
Yeah.
you bring these things up and now the brain starts maturing and catching up, then you're going to see a more normal neurodeveloped child would look like.
Yeah, and it stresses it's more of a dynamic functional model rather than a structural model. I mean, it suggests that this delta isn't always structural, but it's dynamic and functional, and it can be changed rather rapidly, which is an exciting concept, especially for head trauma.
I have a quick question. This is Carl Johnson.
Fellow functional.
Yeah, not quite to the degree that Dr. Kelly's doing, but I just was wondering, I've had several researches I've evaluated to learn about primitive reflexes. I was wondering what Dr. Miller's recommendations might be as far as either digital programs or so forth, written, etc.
On learning how to do primitive reflexes?
Testing and remediation.
Oh, how to get rid of them.
And evaluation.
Yeah. I've got a few up there on my www.savingyourbrain.com. We go through with one of my staff and we simulate the reflexes, and then we show remediation with using the Avant laser, and you basically, let's say we were doing a asymmetrical neck reflex, and we have the person in all fours like they're crawling, and there is a positive reflex, like we take their head and we turn with their eyes closed, they turn to the left, and their right elbow buckles or bends, depending on how bad it is. So what we'll do is put the laser on the right cerebellum brainstem, which is kind of about an inch behind your earlobe, right at next to the occiput, a little 10 degrees headward cephalad, and we can put a metronome on that side, just put on 60 beats, and all we'll do is just turn the head for whatever. It may take a minute, 2 minutes. It could take 4 minutes, 5 minutes, but it will integrate. Now, it has to be done and done and done again. It's just not like do it one time and it's all fixed, but it'll go away, and you will see changes in their heart rate, and you'll see changes in their pupil size, and you'll see a relaxation. I mean, these kids, they'll actually just melt. I mean, when they like they want to go to sleep.
That's cool. So you find that's much more effective than having people try and do a home treatment, reintegration process.
Well, we do that too. Like we would have them do the lizard for that same thing. the lizard is they look to that side and then they're bringing their knee up and their elbow and they turn the other way.
Right.
We still have them do those exercises because
Okay. So you
but
do
we
the same thing in the office, but use the laser on the proper side of the cerebellum slash brainstem.
yeah in the
That we
office
find a weakness on.
we just stimulate it with sound sensory on that side and we can put a vibration on them and that just makes it happen faster. And then we'll laser on that side and we'll initiate the same test that elicits it. And we just do that. But we at home, we have them do the lizards.
Cool. So just using some summation principles to increase the stimulus.
Yeah, just reinforce. And we actually sell laser to, when we have, because we have a lot of really, bad autistic kids and are really bad, or they have two. And so it's more cost effective. They come in for some treatment, but we actually train the parents how, to do a lot of this stuff at the home, in the house, at home.
Excellent. Yeah, I just had a few people get tested this week that were really bad, and I know that they all have some primitive reflexes. So I was like, there's no way they're starting neurofeedback yet. Gotta work on some of these other things, maybe.
Well, I mean, I will do that in all the same session. It's just we do it all in the same sessions. But
Yeah, I just worry about sometimes like the one I'm referring to, like he literally ripped his brain map cap off and just went crazy, so you don't want to get your equipment damaged though.
Right. Well, yeah, we have some that we can't. Absolutely. We have some children that you can't map them initially. So that's a good way to get them calmed down.
Yeah. Get that fight or flight response down. Okay, thank you very much.
Yeah, we're past the hour and everybody has appointments and so forth.
Okay, well, thank you so much for having me.
Dr. Miller, thank you.
Yeah. Thank you,
so
Dr.
much.
Miller, and safe journeys, safe travels. We'll be in touch.
Okay, thank you.